So you are live, you can start now.
Okay, one second. Yes, sir. Good evening, Dr. On behalf of Alcom, myself, Francis, I welcome our moderator and speakers and all doctors who have joined us today for this experience sharing program, like a novel anti-epileptic parenteral in epilepsy management. Alcom has always been at the forefront when it comes to scientific dissemination of knowledge. This program is set up further in that direction to help us navigate through the meeting. We have Dr. Satish Kumar and Dr. Dinesh sir, and hospitalized Global Hospital as a senior director neurology will be having more experience. I would like to invite Dr. Satish Kumar to set context of this meeting and introduce the moderate this session.
Yeah. So we are going a little opposite today. Okay. So it's been always my pleasure to be, with our guru and mentor, Dr. Dinesh Naik sir, who has taught us everything about epilepsy. So whenever the word comes to epilepsy, always as a team we remember Dinesh sir for all the difficult cases, clinical decision making, and everything. So this is a newer molecule, and I think there is no other person in Tamil Nadu or in India to have a good clinical experience with the molecule. Been using this molecule for last 2-3 years once it's been launched, and sir has a vast experience in this field. So we will take his clinical decision making skills, his experience about this newer current generation of parenteral. So I invite Professor Dinesh Naik sir to share his few words and experiences about this molecule and about the program. Welcome you, sir.
Thank you so much, Satish, for the very kind words. It's always a pleasure. We've been working together for the last, this is the 11th year now, and it's going strong. So that's something, having a decade of continuous association, a very close association, not just a occasional one, but it's a very close interaction for the last 10 years is a very big, it's a blessing basically. And that's something that is unique. And I think what we have done is that we have shared a lot of clinical as well as academic decision makings and shared a lot of ideas, have worked together in the field. Now, today's program is all about, and I thank Alchem for asking me to be part of this interesting discussion on this newer molecule. Now, perampanel is, I don't know how many people know about it, but that's the only anti-seizure medicine. We don't use the word anti-epileptic anymore because I don't think there's a single drug which is anti-epileptogenic. So the coinage of the term is now anti-seizure medicine. This is the only molecule which is a designer molecule. It has been designed specifically because all other molecules were discovered in serendipity. If you look at phenytoin, you look at carbamazepine, they were accidentally discovered. And then they found that it's useful for seizures. But this is the one molecule. They found that, there's an excitatory amino acid, glutamate. And then they found that glutamate goes and attaches itself to receptors. And they found that there are 3 types of receptors. And then they found that the AMPA receptor is the one that is important for epileptogenesis. Therefore, they decided to try and find out a molecule which is an AMPA receptor antagonist. So that is how. So it is actually a feed-forward mechanism by which they actually found this molecule. So that's, in that sense, is the only anti-seizure medicine with that property, in the sense that it was designed to be an anti-seizure medicine right from the first point, not discovered as a serendipity. Now, so therefore, Dr. Satish is going to discuss everything about that particular, how it acts and all those things. But in the clinical world and the practice, we've been using it for the last, ever since it came into the country, the last 3 years or 2.5 years or whatever it is. We have a fair experience with this molecule because we are forced to use it because we use it on difficult to control epilepsies. The drug is pretty good, and I've even used it as monotherapy in some instances because that's the natural history of any drug use. You know, you start off with the most difficult cases, then you find that some patients will respond very well, some patients may not respond that well. That's the natural history of any drug. Then you find a cohort of patients who do very, very well, and then you slowly start tapering off the other medications the patient is on. And then finally you reach a point where you'll have only a monotherapy. Then you get enough confidence, and then you try out a monotherapy from the beginning for another group of patients. So that's how we kind of become more and more confident. So that's the learning curve that all of us, learning curve in the sense that we know all about the theoretical aspects, but finally, we have to use it on our patients, and the patients have to have confidence in us. And therefore, they are the ones who are actually going to tell us, whether they like the medicine or not. And along the way, we learn a lot. So that's what is all about. So the theoretical aspects as well as the studies and all that will be, which is very, very important to have an understanding of the molecule. And that's going to be the bedrock or the basis on which we are going to use this molecule. That's going to be Dr. Satish Kumar's job. He's going to talk about it. Then later on, after that, we will discuss on the clinical scenarios in a practical sense, where it's more likely to be useful or whatever it is. So that's, let us now start off like that. Dr. Satish?
Yes, sir. Thank you, sir. So with a good note, with the vast, immense experience, Professor Dr. Dinesh Naik, sir, because we all knew that it's a new molecule, and as he initially told that, I don't know, many of the younger physicians or the neurology colleagues might not have used this molecule, though might have heard it. They don't have any first-hand experience on this molecule. We are lucky that we've been working as a team. We collaterally, parallelly learn from sir and use it and see the outcome, both the clinical outcomes as well as the difficult to treat cases. So, and as well as the side effects too. So let me briefly go into the basics of what this molecule is, and let us go and discuss about the clinical evidence later on with our Dr. Dinesh Naik. So the next few more minutes, I will be talking on the newer molecule, which is Perampanel. So as I told in the beginning, that whatever in epilepsy we learned, we walked through the footpath and footsteps of Professor Dinesh Naik sir in detail in the last 11 years. And I'm happy that I've been working with him, and I have learned a lot about every ABCD of epilepsy along with him. And I immensely, profoundly thank Dinesh sir for that opportunity. This is very basic. We all know that in India too, we have a lot of epilepsy cases like developed countries. In fact, we have more cases, and there are 12 million persons with epilepsy in India, and every year we add on to 2.4 million people. And 30% of people also have generalized seizures, whether it is a primary generalized seizure or the secondary generalized seizures. So this is one of the common slides we keep seeing in all the epilepsy meetings. Whenever we have a molecule or epilepsy meetings, we know that in the last 1 decade, in fact, last 2 or 3 decades, we have booming of all the newer molecules. They are called the third generation molecule, which is quite as efficacious as the primary original first or second generation molecule, though it was invented for the extra efficacy as well as the side effects. So one of the landmark trial, we always discuss about the drug efficacy. When you start a drug, that's a good 47 to 49% of clinical experiences. But when you keep adding on the newer molecule, the second, the third add-on, and the fourth add-on, the percentage of seizure freedom keeps reducing. So after the second or third anti-epileptic drugs, even if you add the best molecule or the novel anti-epileptogenic molecule also, so is there any role of seizure freedom even if you keep adding the molecule. So this is not changed substantially from 2012 onwards. Even we are now seeing the same paradigm. So there is an unmet need in seizure treatment. As we told that in the last few years, we have more and more of molecules which are acting on the new novel mechanisms in the past 3 decades. Said that repeated outcome analysis have shown that 30% still fail to achieve prolonged seizure freedom, and henceforth we need a complete, advanced epilepsy center like in Chennai, what Dr. Dinesh sir is doing here, to how to take a good history taking, detailed history taking, analyze the seizure types, approach the seizure syndrome, choose the appropriate molecule and an appropriate duration and a drug schedule, use the latest drugs for indicated for those conditions, see the outcome, and if not, sometimes there is a role of pre-surgical evaluation for epilepsy surgery. And even though we use a lot of molecules as an add-on, some may not like the molecule because of the adverse event profile. So there is a problem with compliance and discontinuation of the anti-epileptic drugs. Not only that, the adjunctive therapy and the seizure burden increase the risk of death like SODAP, and increase utilization of unscheduled care and cost, like emergency frequent admissions for status epilepticus. And henceforth, there is an unmet need for the newer drugs with improved efficacy and better tolerability profiles. So whether the molecule which we are going to talk will bridge the gap of this unmet need, let us go have the clinical evidence. So the new milestone in seizure management, as already told by Dr. Dinesh Nayak sir, is the anti-seizurogenic, anti-epileptogenic drug among all the anti-epileptic drugs available now. So this is perampanel. So what are the currently approved indications in India? It is initially used as partial onset seizures with or without secondary generalized seizures, also being used for primary generalized tonic-clonic seizures. So it's an adjunctive treatment for partial onset seizures with or without secondary generalized seizures in person with epilepsy aged 4 years and older, primary generalized tonic-clonic seizures in persons with epilepsy aged 12 years and older. So coming to the mechanism of action, so we all know that there is a synapse, there is a presynaptic neuron where the neurotransmitters like sodium, calcium, and potassium channel ions are there, where there is a depolarization shift through action potential. They release these transmitters into the synaptic cleft, and the postsynaptic membrane has a lot of receptors for the neurotransmitters like glutamate, like calcium, to act on and release the excitatory postsynaptic potential. This is the normal mechanism of seizure propagation. So you need molecules to act on different receptors and channels. AMPA receptors are the foremost mediators of excitatory neurotransmitter, and these are the most frequently encountered receptor type in the central nervous system. Perampanel is the first medication to be specifically designed with glutamate inhibition, as among the glutamate receptor is the AMPA receptor inhibition is its primary mode of action. So novel anti-epileptic drug is an affinity for excitatory postsynaptic AMPA receptors of glutamate subtype, which is a selective antagonist of AMPA. It binds to a separate site of glutamate postsynaptic membrane as a non-competitive inhibitor, and hence it prevents the normal excitatory physiological response to glutamate from occurring while still allowing it to bind to the receptor. So it competitive mechanism, it allows the glutamate to act. Also, it prevents the glutamate exotoxicity and producing seizure propagation and ongoing seizures. So when the AMPA receptor antagonism is achieved, it leads to reduced overstimulation and anticonvulsant effects and anti-seizurogenic effect also on the spread of seizure too. Not only that, this antagonism also had a role in neuronal death and apoptosis too. So that means there is more and more of neuroprotective effect of this molecule too. So moving on to the pharmacokinetics, as other molecule, it has a T max of 0.5 to 2.5 hours, quite good. Rapid absorption, bioavailability of 100% through oral route, 95% protein binding, majorly metabolized in the liver and eliminated. T half is 105 hours, is a good long duration of action. Mostly it is excreted in the fecus of 48%, lesser extent in the kidney too. The dosage forms and strengths available in the market are 2, 4, and 6 milligram. And the dosage schedule and the dosages in adult 12 years or old, you start with 2 milligram per day total dose and increase the incremental steps of 2 milligram per day every week to achieve the maintenance dose of 4 to 8 milligram, where majority of the patients become better with this dose. Sometimes you may need to increase the maximum dose to 12 milligram if the seizure burden is quite high and the patient if tolerability is good. In children more than 30 kg, the scheduled dose remains the same like adults, but less than 20, you start with 1 milligram, increase every week of 1 milligram per day to maintenance dose of 2 to 4 milligram. Between 20 and 30 kg weight, you start with 1 milligram, increase 1 milligram per day interval of every week, then maintenance dose of 4 to 6 milligram per day. Whether you need any dosage modifications in kidney, liver, and other drugs, yes, in kidney and hemodialysis, end-stage renal disease is not recommended. In severe hepatic impairment, it is not recommended. If it is a mild hepatic impairment, it is used to the maximum dose of 6 milligram. Moderate hepatic impairment, we can use to the maximum dose of 4 milligram per day. Suppose when we are using with other anti-epileptic drugs like enzyme-inducing property like phenytoin, carbamazepine, oxcarbazepine, you start with higher dosages because it clears the level of, decreases the level of perampanel effect in the blood. So you have to use the initial dose of 4 milligram to achieve the seizure freedom and then increase 2 milligram in weekly interval. The common side effects in the original study as well as in the clinical phase 2 and phase 3 extension studies show that dizziness, somnolence, fatigue, irritability, nausea, weight gain in some population, headache, vomiting. These are all the common side effects reported across in all short-term and long-term studies, even post-marketing surveillance too. Drug interactions, as I told, along with other, cytochrome enzyme inducers like carbamazepine and phenytoin, these drugs increase the clearance of perampanel and decrease the plasma concentration of perampanel and hence therefore decrease the effectiveness of the drug. So dosage adjustment is necessary as I told before, so you have to start with 4 milligram straight away. Oral contraceptive pills, when you use estrogen containing oral contraceptive pills, 12 milligram or even 10 milligram of perampanel decrease the efficacy of hormonal contraception and hence you should be careful in counseling the patient. It is not recommended in other enzyme inducers like rifampicin and other drugs. Coming to the clinical evidence, the trials for both partial seizures as well as primary generalized tonic-clonic seizures, as compared to the placebo, when you compare this molecule of perampanel in various dosages of 2 milligram, 4 milligram, 8 milligram, 12 milligram, the percentage of shift of change from the baseline seizure frequency in generalized tonic-clonic seizures, primary generalized tonic-clonic seizures are 76% as compared to placebo of 38%. In partial seizures, 8 milligram or 12 milligram is well tolerated and reduces the seizure frequency median change of 28%. The 50% responder rate is quite comparable significantly as compared to placebo in both primary generalized tonic-clonic seizures and partial onset seizures. Complete seizure freedom is achieved in 23.5% of population in primary generalized tonic-clonic seizures and around the tune of 4.5% in partial onset seizures. So it was significantly more effective than placebo in controlling seizures in terms of reduction from the baseline in seizure frequency, 50% responder rate, and seizure freedom too. So the complex partial seizure arm, as well as without secondary generalized seizures, all the dosages shows, the 8 milligram and 12 milligram have a statistically significant reductions over placebo in median change from the baseline. 50% responder rate is almost comparable in 4 milligram and 8 milligram and 12 milligram dosages in as compared to the placebo. So coming to the safety and tolerability, we all know that it is safe and tolerable up to 12 milligram per dosage in long-term follow-ups. The most common phase 2 dose escalation studies were dizziness, 57% of population, somnolence in 30% of population, and headache. Sometimes few patients reported diarrhea and rhinitis as well as some infections. Rarely elderly falls and all those behavioral side effects, aggression were also been reported. Having said that, they didn't found in the original trials as well as in the dose escalation and long-term tolerance study for a period of more than 52 weeks. Also, they didn't find that there is no treatment emergent adverse effects or deaths reported through perampanel. This is again the phase 3 studies. Again, with 8 or 10 milligram, they found the same side effects like dizziness, somnolence, and headache and fatigue. In elderly population, whether this drug is safe or not. So, perampanel efficacy was similar for adults and adolescents in real-world studies, but elderly people with refractory focal seizures experience greater seizure freedom than younger persons. This is a surprising fact. They found that though the side effects were there, but they found that elderly population are the one where they found less side effects, better tolerability, and better seizure control than younger patients. Children and adolescents, they also found in the randomized controlled trial between the age group of indicated age group from 12 to 18 years, they found with focal seizures without secondary generalization, they found that the median reduction in seizure frequency from baseline was 58% for perampanel as compared to the placebo. The behavioral side effects were comparable. There was no statistically significant behavioral side effects noted in these children and adolescent population when they use this molecule as compared to placebo. But however, aggression was more frequently reported in the tune of 8% versus 2% in the placebo. So this is the most commonest side effects noted in the pediatric population. This is quite interesting. This is case reports of multiple seizure type. They found a open trial of 10 patients with epileptic encephalopathies like progressive myoclonic epilepsy like Lafora disease. They used this perampanel, the medication regimen, and they found that the average number of generalized seizures for 28 days was baseline was 6.4 and was decreased to 2.2 and 2.8 at the follow-up of 3 and 9 months respectively. Not only that, there is a reduction in the myoclonus severity and intensity from the baseline, and some patients out of 10 withdrew the molecule because of compliance and the lack of effect and the adverse events in multiple seizure types and encephalopathies. Comparison with the newer drugs, this is not a classical randomized double-blind control trial. This is in comparison with the placebo in various other trials. They found that in the meta-analysis of 7,823 patients with both partial seizures with secondary generalized tonic-clonic seizures too, in 24 RCTs, to investigate the potential difference in response to these various drugs, they found comparison with these 7 drugs: lacosamide, pregabalin, tiagabin, topiramate, vigabatrin, zonisamide. So these are all good, quite newer molecule with good efficacy in various seizure types and syndromes. They found that the 4 molecules like perampanel, lacosamide, topiramate, and these 3 molecules have a better significantly reduction of secondary generalized tonic-clonic seizure frequency than placebo. So this is the in comparison with other drugs. So this is the licensed adjunctive treatment for primary generalized tonic-clonic seizures. The efficacy summary. We all know that for the primary generalized tonic-clonic seizures, we use, apart from valproate, which is the second generation molecule, we use the newer molecules like levetiracetam, lamotrigine, topiramate, sometimes zonisamide, and the molecule like perampanel. If you see the median reduction in seizure, primary generalized tonic-clonic seizures, the highest was there for levetiracetam, and perampanel to the tune of 76 to 77%. But complete seizure freedom is almost comparable to levetiracetam maintenance dosages of 3 grams as compared to 8 to 10 milligram of perampanel. So almost 36% of population of complete seizure freedom. So this is the efficacy summary of this molecule in primary generalized tonic-clonic seizures. Now we talk about various seizure types, its efficacy, its adverse events. Now come to the long-term safety. Is it the phase 3 extension study? They found up to the 52 weeks of more than 867 people, 71% of them have the dose of 10 to 12 milligram are tolerable, and they have a good efficacy and good tolerability even with highest recommended dosages up to 12 milligram. So this is the median change in seizure frequency across the 4th year, though the seizure frequency is keep decreasing after first or second year because of its refractoriness, but it is quite tolerable also. The responder rate is better in the subsequent years. What is the real world data post-marketing surveillance studied both in Asian population as well as in European population? This is a trial in Europe, pooled analysis, multicentric trial, 2,396 patients, 95% focal seizures, median prior AEDs were 6. 1 year retention rate was 50% in primary partial onset seizures. Seizure freedom is up to the tune of 9.3% in real world data, and the median treatment duration was 11.3 months in this trial. So we have been brushed upon mechanism of action, dosages, dosing schedules, bioavailability and its pharmacokinetics, clinical evidence in partial onset seizures, secondary generalized tonic-clonic seizures, primary generalized tonic-clonic seizures, comparison with the newer second and third generation antiepileptic drugs, its real-world data, long-term safety and efficacy. So, said that to summarize, it is the anti-epileptogenic novel non-competitive AMPA receptor antagonist with neuromodulation effect on postsynaptic glutamate receptor, is convenient once daily administration, the broad spectrum activity, no predominant proconvulsive property among all the seizure types, approved both for partial onset seizures and primary generalized tonic-clonic seizures, also approved in pediatric population, more than 12 for primary generalized tonic-clonic seizures, more than 4 years for partial onset seizures without secondary generalization, 100% bioavailability, safety and tolerability is well established, minimal side effects like headache, dizziness and somnolence and fatigue, and a Tmax of 0.5 to 2.5 hours after the dosage, which is quicker action, onset of action, longest once daily dosages. So these are all the advantages of this molecule. So I stop here and I take inputs from the audience as well as Professor Dinesh Naik sir to share his experience on this, his clinical complex case vignettes and the expertise of this using this molecule in real case scenarios from his difficult to treat cases. Thank you, sir.
Thank you, Satish. It was a very, very comprehensive, very nicely, very lucidly done, very comprehensive. You covered almost the entire thing in just about 20 minutes. And it's remarkable that you did it in that span of time in a very clear and a cogent manner, very, very nicely articulated. Yeah, you could see that the molecule is definitely useful for both focal seizures as well as for generalized seizures. And what we are actually beginning to learn is that in certain subgroup of patients, it's more useful than many other molecules. And I'll just list out a few, both based on our own experience as well as from the literature. And the one is that, especially in bilateral or unilateral unifocal occipital gliosis, and this is pretty common in our country, where you see these children, because of the perinatal hypoxia, they have these occipital gliosis. For some reason, there's a lot of AMPA receptors that are expressed in those gliotic tissues. That's been shown And therefore, it makes sense to use perampanel in that group of patients pretty early, so that it's as maybe a first add-on itself, and then see whether that is responding. So now our practice is that if the patient is a potential surgical candidate but is not, getting seizures but not. So first thing what we do is now is to try a course of a trial of a 6-month trial of perampanel and see what's happening to the seizure frequency. If they remarkably come down, then you just wait. If it doesn't, so that's the kind of practice that we have been trying to follow now. And we're using it even before it actually got recommended for 4 years and above. We've been using it even earlier than that as an off-label kind of a picture, because we get very difficult to control epilepsy. So we are forced to use it. And we found some very good results based on that. So that's one group, occipital gliosis. The second group where it is very useful is these reflex startle seizures. That is another group which is very, very useful. And I've had a patient, it is quite remarkably useful, I would say. But not the reflex eating epilepsy, but the other reflex epilepsies where there's a somatosensory startle or auditory startle, where they just have these kind of asymmetric tonic and then they kind of fall off the tonic seizures. And if you look at the perampanel's action, it kind of delays the somatosensory evoke potential, the peak. And in all these startle reflex epilepsies, you find that when you see the SSCP, you have a large peak, giant SCPs. And that's one of the common features of progressive myoclonus epilepsies. There's quite a common feature in the reflex startle epilepsy. And it has a way of blunting that peak and therefore reduce the cortical hyperexcitability. So that's another group. And I have managed to, in one of our patients, common patients, Satish would probably know. And, every time he touches the lip, he would just have that thing and he'd fall off. And then remarkably now, he's only on perampanel at 8 milligrams, 8 and 10 alternate days. He's completely seizure-free. That's completely remarkable. And he could be weaned off all other medications. And he's on a monotherapy. That's something remarkable, because every time he touches his upper lip, he would have this kind of reaction. And he just can't brush his teeth because it would result in touching his mouth and feeding and all that. So that's one group. So reflex startle epilepsy syndromes. Lissencephaly. That's not a very common, obviously it's a very rare entity. But again, it gives you an idea about the mechanism of action. And that's why we are talking about it. In lissencephaly, or what is called a smooth brain, and they present as various kinds of drug-resistant epilepsies. And what happens in lissencephaly is that the neurons fail to migrate properly, and then so those radial neurons which go and migrate to this cortical surface, they get stagnated at different places, and then they produces a lot of migrational abnormalities, smooth brain, all kinds of things. And those neurons also have a lot of AMPA. So again, that is another group. And so and I have got now, based on that, we have got a kid now who's on perampanel, who's pretty normal now. In terms of the seizures, not in terms of development, obviously, but in terms of seizures. So that's another group. Lennox-Gastaut syndrome, because of other conditions, very bad epilepsies, that's another group, especially with these tonic seizures. Atonic falls in a Doucet syndrome. There's a condition called Doucet syndrome, where suddenly the head drops because of loss of tone. The tonic seizure is one where there's a tightening of the limbs and then they fall off. But in Doucet syndrome, they just drop off. They also drop off if they're standing. They suddenly fall on their buttock because the knees give way. That's a very painful. They get badly bruised bottoms. So that's another condition that can be that is particularly useful. And in refractory, there are some 5% of idiopathic or genetic generalized epilepsy syndromes like JME or some other cryptogenic generalized epilepsy syndromes, which usually respond extremely well to valproate or, which is the #1 drug for genetic generalized epilepsies. And if they don't respond, there's about a 3 or 4% of patients who don't respond to valproate. And generally what is said is that if they don't respond to valproate, they generally don't respond to other medications. So it's a kind of drug-resistant generalized epilepsy syndrome. The valproate resistance is a marker of bad generalized epilepsy syndrome. And in such a patient, if you use perampanel, they do well. They do quite very well. So that's another group. So these are some of the groups that I've used. Many times I've used it as a third or the fourth add-on. That's how we start off. Now with more and more experience, you use it as a second add-on. And in these groups, I would add as a right at the beginning itself. And then we are gaining experience. So that's my experience. I've told I would like the audience also to participate and Satish's experience itself, and that's
quite a very clear thought process, sir. I think it's beyond anybody's approach. I think you have nicely dissected out the pathophysiology and its seizure propagation and the efficacy of perampanel. So though it's not been commonly thought of in all the guidelines, I think the future in difficult to treat epilepsy itself should have a separate guidelines they should publish than for the common axis like the IgE syndromes, focal seizure, secondary generalized. They should have a special scenario where what are all the options available as level A indications. We don't have it. ILAE guidelines for that. I don't aware of that. So in that scenario, I think these molecules play a role in subset of populations like what you have clearly told. So common questions people might want to know is its role in whether it is useful during women with reproductive age group, pregnancy, breastfeeding, and other conditions.
I don't know. I mean, women with, I think the data is rather sketchy at the moment. So we don't know any of these newer especially these are all called, what are called third generation anti-seizure medicine. So the data is a bit sketchy. But so I think it's still category C. So we really don't know. We would hesitate to use
it. Like lamotrigine or levetiracetam, we don't have.
Okay. No, we don't have. Yes, you're right.
Even for brivaracetam and
yes. Yes. So it's still category C. So we would not recommend at the moment, or there's no guidelines to recommend this during pregnancy. So that's one of the problems. Yeah.
So the other points want to know from you, sir, is there any compelling major side effects in your case scenarios where you know that molecule will definitely work, but the patient is not tolerating it, and there are some instances?
Yeah, I mean, that's true. I mean, obviously any drug, works very well in majority, and then and some people, they just can't tolerate. And generally it's, dose dependent. And if you, especially for this perampanel, one of the advantages of perampanel is that it's a once a day dose. So that's a big advantage in terms of, because when you're using for epilepsy, it's better to use something which is once a day. So that's good. Very long half-life, 100 hours. So obviously it goes to hang on in the blood for about 4-5 days. So once a day. Therefore, because it's got such a long half-life, so it's better to titrate it very gradually. So generally, I generally do it over every 20 days or 25 days. Any increase, so 2 milligrams. And I'm a bit careful. I would, instead of going to 4 straight away, what I've learned is that I would use 2 and 4 on alternate days. So that, what I found is that sometimes from 2, when you jump to 4, in our patients, about 15-20% of the patients would come back and say, because the boys become a bit irritable and this, that, and all that. But if you do this method, 2 and 4 on alternate days, so they'll be actually having 3 milligrams on an average, that goes off. And then after another 25 days, you make it 4 daily, they tolerate it. So I generally do it as 2. Sometimes I do even 2 alternate days to start with, but generally it's 2 per. I mean, I don't make it alternate days for more. I mean, I would use 2 as straight away as a starting dose, but 2 and 4, then 4 and 6, 6 and 8. That's how I do it. I've gone up to 12. At 12, I think very few. Maybe I would have used it only in about maybe 4 or 5 patients. All of them have done well and they're all right. But when you reach, there are many patients who from 8 to 10 you go. 10 they become a bit this thing. So you bring it down to 8 and 10 alternate days, they become all right. So these are some of the tricks that we use. So if you go very slow and if you're patient enough and you tell your patient that, yeah, it's going to take about 3-4 months, so you have to be patient, then you have no problem. But irritability is one thing. Most of the time it is that. In children, it's irritability. Sometimes, there's a black box warning also that, sometimes they may be pushed to kind of some kind of a suicidal tendency and all that. But that happens in some of these anti-seizure medicine anyway. So, but this you have to be a bit careful. Irritability is something that is one of the problems. Some kind of somnolence.
So in which which set of population you find that they tolerate this? Like elderly, children, and adults.
Oh, that's a good.
We have a lot of pediatric population, but still.
We use the population that we have used is mostly pediatric and young adults. I don't think I've used it in elderly as yet.
Because the falls are one common side effects.
One of the problems is that falls can be there, unexpected falls not related to epilepsy. Non-epileptic falls and can be injurious, and that is usually seen in the elderly. We don't want, our basic idea in elderly is that you want to prevent them from falling down. We do not know what's the percentage of people who will have a fall, but if it, for them, even if it is one person, and if it is because of the medicine, then that's a problem. So I think that's there. But, there was, I think it was Ikeda, who's an expert on, all these electrophysiology of the motor cortex, all that. And then he, in his series, he would put it as something like 1 in 100 or something like that, of people above the age of 50, 55 who have had falls, and they suddenly lose tone and they fall off. And I think it's something to do with the again, the same thing, it kind of, it's some kind of an atonic feature, which I think it's something to do with the negative component, the motor negative area that gets activated or something like that. They just lose tone and they fall off. It's not epileptic. Because it's useful for atonic seizure to start with. So that's the paradox there.
Yeah.
So that's an interesting.
So epileptic falls will be avoided.
Yeah, I think epileptic falls are avoided, but you get non-epileptic falls sometimes in the elderly, but not in children. Yeah, I haven't seen any patient. I don't know whether you have.
No, we in more than 40 plus population, we never use this.
I haven't used
4 patients as an adjunctive therapy on perampanel. Started from our video EEG center only, but after that we are following it up there. Maximum I have used up to 6 milligram. I never gone beyond that.
Okay.
Along with other molecules. So now the same question, which is when you are utilizing this molecule and you found it is effective. So what are all the synergistic molecules you will be comfortable with these, and what are all the molecules? As we know that we should be careful with phenytoin, carbamazepine.
Yeah, very, very excellent point. Very good point. As you first thing, I'll go with the synergy first.
Yes, sir.
And the synergy, I think, is best with zonisamide.
Okay, sir.
I think there's a lot of if you use perampanel with zonisamide in a group of patients who have either generalized epilepsy syndrome or even a focal epilepsy syndrome which is not well controlled, they seem to do very well. The mechanism of action is different, and so you utilize different kinds of things. And for some reason, I think it kind of works very well. So that is one thing that I will definitely be looking out very actively for. Now, if somebody's, that's my kind of a dream combination.
Yes.
Zonisamide with the perampanel. The ones, see, as you rightly pointed out, no, if you with these enzyme inducing drugs, and many of them, obviously in our country, we use a lot of first generation anti-seizure medicine, and all of them are enzyme inducers. So the dose of perampanel will have to be increased, because 2 milligram may not be 2 milligram, maybe only maybe 1.5 or so, because about 20% reduction is there. So that is something that we have to keep in mind. And so you have to up titrate a little bit. If your target dose is 6 milligram, then you may have to use 8 milligram, because that will be like using 6 milligram. So that is something. So you should not say that, oh,
Not effective.
6 milligram, but it's not very effective. So that's sense. So phenytoin carbamazepine is something that oxcarbazepine to some extent, much less extent. But these are the two drugs that can increase the. Yeah, so that's the drug interaction part of it.
Last questions is like the clinical evidence and the literature says that the efficacy is quite good in the molecule in the seizure freedom, as well as the percentage of seizure reduction is highest in the primary generalized tonic-clonic seizure, as compared to our experiences like partial pediatric population in generalized tonic-clonic seizures. Do you still agree on that?
I think
whether
it's a good point. I mean, it's a good point. I've learned this lesson very recently. I mean, maybe about 6 months back. And this man, I think you also know about him. And we've been following him up for the last 5 years. And he's got a classical pattern of a generalized epilepsy, and he's developmentally normal. So he's not some kind of a symptomatic generalized epilepsy syndrome. He's definitely an idiopathic generalized epilepsy syndrome, but not responding to good doses of valproate and zonisamide, all kinds of things. Now, this man, I had not much idea. I don't know why it slipped off my mind, but somehow the perampanel was not used. And about 6 months back, he became psychotic at some point, and then he started becoming very, very restless, and then after a seizure and shoulder dislocation and all that. And then he was brought back. He was in Bangalore at that time. He was brought back here, and I saw him again. Had to use a lot of antipsychotic drugs with the help of a psychiatrist. But still, his seizure type was still the generalized tonic-clonic, and we had done video telemetry and all that. And for all his cocktail of medicine that he was on, with improper control, and once a month he would definitely get a big one. And then I added perampanel. And in the last 7 months, from January till now, he's not had a single attack for the first time in his life. That's completely remarkable. And now he's slowly being weaned off all other medicines. And he's off the antipsychotics also. He's become normal. That's remarkable. For me, that is the evidence in the clinic that in generalized epilepsy, I think it's worth using perampanel. Probably what I would do from now on is that if somebody is not a good candidate for valproate, I would straight away start off on perampanel. That's my this thing. Yeah, I think I would use it early, not try out the others and then come to perampanel. So that's something, because again, you can use it once a day, and then if it is working that well, it's very good for myoclonus. So PME syndromes, Lafora body disease, all that, because what it does is again, you go back to the physiology of the brain. AMPA receptors are ubiquitous. And the point is that AMPA receptors, they generally are used for fast propagation, fast EPSPs, excitatory postsynaptic potentials. Whereas the NMDA receptors, they are the they don't mediate fast EPSPs. They mediate only slow EPSPs. So therefore, they don't participate that much in seizures. So NMDA also is very ubiquitous, but they are non-seizurogenic in that sense. The glutamate does not really this thing. It produces many other conditions like memory disturbances and all that because it's used for long-term potentiation. So this, so in a cortical hyperexcitability syndrome, and all these cortical hyperexcitability syndromes, like your reflex seizures, your
AVs,
progressive myoclonus epilepsies,
encephalopathy.
AMPA comes into the forefront. And the myoclonus is a very important thing, and this is very useful for that. So I would strongly recommend the use of perampanel for that.
Yeah, it has a good feature.
It's a good feature.
Topiramate we use as an anti-NMDA effect for status. Do you agree? Do you have a different opinion? Because you keep telling us that during status, AMPA receptors get internalized. So in that scenario, if the patient comes with a status in the ER, so what will be the role of patient who are already on perampanel, or whether you can still continue perampanel, or whether you add on with perampanel?
Oh, that's a good point. I mean, there are reports of the use of perampanel for status epilepticus itself.
Oh.
And it has been used. And recently we had a nice talk, and then there was a nice discussion. And Professor J.M.K. Murthy, who's an expert on status epilepticus, and he was the first person, at least in our part of the world, to advocate the use of high dose of topiramate.
Yes, sir.
For initially. So they can actually be prevented from, refractory, status. So if somebody is not responding to phenytoin and this thing,
Valproate
start with, immediately you load them with some, huge dose of topiramate, 10 milligram, 20 milligram per kilogram, straight away start off. That would prevent. And I've also used that in Sri Chitra those days. We have used it, and that would be. Now, Professor Murthy recently, the kind of dosage that he uses perampanel, I got shocked. And he says, no, I use 36 milligrams of topiramate, of perampanel. This 8 milligram, 10 milligram, 12 milligram and all that. No, 36 milligrams he uses. And he has shown some 4 patients who become completely all right.
Okay.
So, so I think I got a complete shock with that, but I think he is a pioneer in that field. So yeah, it's wonderful. So I think there is a role. There's a role. So what his point is, don't bother about anything, just load them. Don't bother about psychosis, this, that, and all that. You just give huge dose. 24
dose also it is safe. It won't produce any
hypotension,
hypotension, cardiac.
It's safe. It's not. It doesn't produce anything.
That was a learning from them.
Yeah.
Great, sir. So lot of pearls of wisdom in short span of time from
I think it was a nice
new molecule which we never thought we will be knowing about this amount of experience in a short time. Thank you very much.
Yeah, it's thanks to our patients who have belief in us. They come back. So we learn from our patients. So we learn from textbooks, but ultimately, when we have to use it on our patients, they have to come back and tell, no, I'm all right or I'm not all right. They have to also come and tell us that I'm not all right. Then only we learn that what is happening, why is it not all right. So I think we have to thank our patients and the faith they have in us. Thank you.
Thank you. I think there are no questions. Francis and Jagdish.
Yes, doctor. This is Francis, regional manager from Malcolm Pentagon, South Zone. So at the outset, I take this opportunity to thank you for sharing your expertise on this very important topic. The information you shared were very useful and practical. I'm sure many of doctors watching it would have benefited from the experience of our faculty. I would like to thank you, Dr. Dinesh, sir, for beginning all the relevant points into the discussion, for making this session useful for all the doctors. I would like to thank our speaker, Dr. Sadiq, sir, and all the doctors who have been joined us for this program and making this program successful. Healthcare for all is our commitment at Alta. We solicit your new prescription support for Aparatus. Our brands are available at most of the chemists, but in case of if any patient finds any difficulty, I would request you to connect them back to us to solve the conflict. Thank you, and please take care of your health while serving the patients. Thank you so much. Thank you for inviting us.
Thank you very much, Mr. Francis.
Yes, sir. Thank you so much, sir.
Welcome team.
Give you valuable time you spent for this Perampanel meeting, sir.
Yeah, thank you. It's always a pleasure to
I
be
think
with
this is,
Satish.
I think, if recorded, it should be a useful tool for those.
Useful to share to all the.
Yes, because learned a lot in a short span of time from this.
It's
Thank you,
always a
sir.
pleasure to be with Satish. Thank you.
Yes. Thank you, sir.
Sir, and Dinesh, sir.
Thank you, sir.
Thank you.
Thank you very much.